right, everybody. So we're going to go ahead and get started here. Thank you, guys, for joining us for our Precision Medicine Prevention and Early Detection block. So I'm happy to introduce Kevan Sims. Kevan is the Associate Vice President for Precision Medicine at Ochsner. He also happens to be my dyad partner. So we work really, really closely at work together, and Ochsner's under a dyad model. If you don't know what that means, we kind of live and die together. We have the goals. If we succeed, we succeed together. If we fall, we fall together. So we got to have each other's back, which is really good. So all right. Well, with that said, I'll hand it over to Kevan, who's going to be talking to us about population-based hereditary screening. I think this is a really important topic, and the work he's done has been absolutely instrumental in growing not only this program, but really a precision medicine program that's getting international attention across the board. So thank you for all your work.
Don't clap yet. Don't clap yet. Wait, it might be yours. So Dr. Matrana talks about our dyad partnership, and I kind of say it's like we're work wives, or he's my work wife. So we kind of have that kind of relationship, which works out well. So as he said, I'm the Assistant Vice President for Precision Medicine. I've been in this role for about 5 years. Prior to this, I spent 20 years of my career doing healthcare IT, both Cerner and Epic integrations and oversight, project management office. So my expertise is not in the clinical space. I am probably the least clinically expert person in the room, but my expertise in workflow, process development, integration, and figuring out how to get things in place is what we'll be talking about a little bit today. So a little bit about the outline, just a bit of an introduction to hereditary cancer, problems and goals that we have, a brief look at our genetic wellness assessment and how we've implemented that, our high-risk clinic, a little bit of question and answers, and then we'll have a QR code at the end in case anybody wants to try out the tool for themselves. Okay, so you guys are likely aware of the prevalence of hereditary cancer. More than 1 in 8 cancers may be caused by inheritable genetic changes, and the impact of those changes, everything from adjusting of cancer screenings, possible risk reduction options, efficient cancer treatments, and then helping to also identify at-risk family members to ensure that they are getting the same testing as well, to ensure that, that we understand and they understand what their risks are. And so some of the challenges of hereditary cancer detection. So how do you know if you are a candidate for testing? Cancer at a young age, more than one cancer, a lot of family history, unusually rare. And just as a little bit of a, here we go. Oh, no. Well, you can imagine that this was 2 versions of NCCN guidelines that change very quickly within a course of a couple of months. And so the purpose of this slide was to just kind of demonstrate that they are changing very quickly. So it's very difficult for providers or patients or really anybody that has a touch with this to understand what those current guidelines are, to understand what your risk factors may be to get you into genetic testing. And so we do a little bit of rewind back to 2023 and where we kind of started this journey. We had 2 genetic counselors in the system. We did not have standards for genetic testing. We did not have discrete results to easily identify patients. And we hoped that patients didn't fall through the cracks for their screening needs. The reality was that patients bounced around from GI to GU, to breast, to derm, to wherever they needed to go, subspecialist by subspecialist, and we really kind of did not have a lot of coordination for follow-up and tracking. Primary care was also really unable to effectively manage due to lack of expertise, complication. Those visits are like 20 minutes long, so trying to have primary care figure out what all of those things need to happen for a patient in that 20-minute window was really not an opportunity for them to really spend that time to do. And so it largely didn't happen. And so the high-risk patients largely were left to their own management. All of my pictures are like, here we go. So that's the patient that is left to their own management. Okay, so the Angelina effect. So several years ago, Angelina Jolie had identified as having a BRCA, and she had a double mastectomy prophylactically. And so as you can appreciate, The complications with a BRCA, everything from breast cancer to ovarian cancer, melanoma, pancreatic cancer, and others, there's just a lot that goes into understanding what your screening needs may be, not just from the gene, but from the age, the family history, the personal history, and a lot of other various factors. So just because you have a gene doesn't mean that you have the same treatment or same screening needs. It's going to vary based on your own personal factors beyond just your genetics. And so we had some goals. So our goal is to create a hereditary cancer and high-risk program. And this was intended to identify patients who meet criteria for genetic testing, staff up to meet the demand. Those 2 genetic counselors weren't going to be sufficient. Train high-risk providers through the City of Hope course in California. Develop standard protocols for high-risk screening needs, and to heavily leverage our electronic medical record for workflows, clinical decision support, and patient tracking, so that we can help to automate both for patients and providers what to do with their high-risk needs. And so currently what we've done is we have a genetic wellness assessment, and we'll talk a little bit more about that. We've staffed up. We now have 10 hereditary cancer genetic counselors who do counseling and testing. We have 6 high-risk providers in the system who will have yearly or bi-yearly visits with referrals to specialists, diagnosis, testing, and follow-up. These are essentially serving as a primary care provider for these patients to a large extent to help them navigate all of their needs. This reduces the burden of specialties. So instead of specialists having those individual visits, those specialists can focus on the surgeries and the more complicated conversations with them, while the high-risk department is taking care of all the kind of the daily needs. We also have a standard genetic panel that we have fully integrated in with both orders and discrete results in our electronic medical record. And we have protocols that are in development, as mentioned, by age, by gene, by sex, by history, et cetera, so that we have a little bit more of an easier way for our high-risk providers to know what to do with those patients when they come in, so they're not having to invent the screening needs for that patient for each time they come in, for each individual unique patient. And then we're also working on building reminders to both patients and providers when the patients are due for screening, so that nobody has to remember. So the electronic medical record can be in place to remind that you need a mammogram or your MRI or whatever that screening needs. And if you haven't had it done, the plan is to send reminders to both patients and providers. Okay, bunch of check boxes, all out of order. So our GWA. So it is a hereditary cancer screening tool that aids in the identification of hereditary cancer syndrome and facilitates cancer prevention and early detection for patients at high risk. We use a lot of branching logic. We have about 127 total processes that are organized to minimize patient burden. It's a minimum of about 2 questions, maximum of about 24, and it takes about 10 to 15 minutes to get through. Our goal with this was to get to yes as quickly as possible. So we're not trying to capture the entire patient's family history. We're not trying to integrate that into electronic medical record. We're just trying to get it as quickly as possible for the patient to know if they need it or not, so they can get out of the questionnaire and move on to scheduling an appointment. I don't know if this is going to work. This was a little video that I thought was going to work out well. It didn't. I could push on it. So thank you. That's what I was looking for. Okay, so you can imagine this is like the entirety of the workflow that we have built. This is the Visio version of it, and it has all the various pathways, and the pathways will kind of go different directions based on the answer of the question for the patient. And so instead of having to fill out all of these, this is the mechanism that we have used to streamline it to make it as quick as possible for patients to get through. The video was very compelling, so I'm sorry that you missed that. But so the GWA, so this is a bit of insight into what the patient sees. So we send a MyChart message to patients. We use it's a tool in Epic called Campaigns. So we automate all of this. So the system is just running every day, and it's sending out genetic wellness assessment messages to patients, so they get that in their MyChart message, and they're able to go and fill it out themselves. It is a screening tool. It looks for the major criteria for genetic testing, and if the major criteria are met, then we will let the patient know that they've met criteria, and we'll do that immediately as soon as they get to a yes, and then that allows them to move into the next step of working towards scheduling their appointment directly, real time, in Epic with the providers. What it doesn't do, so it's not 100% sensitive or specific. It's not all of them, and it's also not perfect because patients don't answer the questions correctly. They don't know if it was an ovarian or a stomach or whatever it is, and they answer the wrong thing, and then they actually get into the visit, and they don't meet criteria at all. But, you know, we can only do as good as we can do with what the patients know and what they say. However, if they don't, we still do offer them a mechanism to meet with a genetic counselor if they would like to. And we actually get quite a few patients that are just like, I know if I don't, it doesn't matter if I meet criteria or not, I still want to meet with you guys just to kind of understand what's going on and see if I want to get tested anyway. And so what happens after genetic testing? So this is the migration from those patients going from genetics to high risk. And so we coordinate those complex and always evolving multidisciplinary patient care pathways. So we work with the specialists that are in the system. We've actually just recently stood up a group of subspecialists that we will work with to understand what are their specific guidelines for how to screen patients based on their specialty. So between gynonc and all of the circles that are here, we take that information to develop those pathways, and that's one of the things that we are working on today. Some of the downstream effects of this, obviously, is that it builds awareness around hereditary cancer and prevention. We'll build patient loyalty with this because as patients come in, what we're learning is that if we have genetic testing with those patients, they are much more likely to stay with us because that genetic testing is important to them. And then there's also the market differentiation, and there's significant downstream revenue that comes from these patients as well. And so some of the key takeaways, just recognizing that the hereditary cancer syndrome can improve cancer prevention, detection, and outcomes. Our GWA is all-in-one screening tool available, and it can be administered as an EPIC questionnaire. Our campaign will automatically push it to patients and allow them to both meet criteria, decide that they want to have a visit with a genetic counselor, schedule that visit with a genetic counselor. So the first contact that we will have with a patient will be at the visit. And so having the tools facilitate everything from identification of patients who may meet criteria to have the visit allows us to really kind of scale this at a pretty significant pace. And then we're developing those clinical and EPIC support systems. Okay, so before we get to Q&A, I'll put this up here. If anybody is interested in doing it, you should get, I hope this works, you should be able to get directly to the site to be able to go through the questionnaire yourself and see if you might meet criteria. All right.
If you meet criteria, you can schedule right.
Just do it, yeah. And if none of that works, then tell Stephanie. Any questions?
Yeah, let's take the genetic book.
Okay, good. Whew, okay. Very good. Yes, ma'am.
I was just wondering, if anyone who's on EPIC can access this program, is that correct?
If any, like other institutions, you mean?
Someone who's already has a chartered EPIC,
Mhm.
for example, I said Tammany Parish Hospital,
Mhm.
if they need genetic screening because of a family history of pancreatic cancer, for example, how can they access the system? Just scan the QR code
Yep.
and answer the questions.
Yeah, exactly. And it's not just for it's for whether you have an EPIC record or not, whether you've been to Ochsner or not. This is for any patient or any individual that's out there that would want to do it. It goes through. It uses our EPIC tool, our MyChart tool, but this one is the web-facing version, so it allows you to, even if you haven't been a patient before, to complete the questionnaire and then register.
I think the website is oxford.org/genetic wellness survey.
I believe you.
I think, yeah, if you talk about Google Oxford Genetic Wellness Survey, anybody in the world can take it. So, you don't have to be an Oxford patient or any patient with me.
No, I was just gonna tell, we have access to it from Centene.
Okay, and is
And
the
John,
genetic,
and I transfer on site.
the genetic consult, is that done at?
Arlen and I will get you the info.
Okay, great, thank you.
Yeah.
Okay. Yes, ma'am.
If you have no family history and adoption or whatever,
Mm-hmm.
would you still be able to do this?
So you wouldn't meet NCCN criteria for it, obviously, but our genetic counselors would have that conversation with you to talk about what other risk factors you may have. and then determine if it's still something that you would want to move forward with. You'll probably have some implications with insurance coverage with that, but the partner that we use for testing does help to reduce that out-of-pocket cost through financial assistance programs. So yes, if there are people that are adopted or don't know about their family history, but are still very curious about their genetics, we would still recommend that they see a genetic counselor. Very good. All right. I'll be here all week. Thanks, everybody.